Next, we will hear from Dr. Erin Brown, the Catherine C. Henson Professor of Law and Director of the Center of Law, Health, and Society at Georgia State University College of Law. Her research focuses on healthcare markets, consolidation, and cost control. Erin?
Great, thanks, Kate, and thanks to NIHCM and my co-panelists for putting together this fascinating webinar. And we are all coming at it from different angles, and so I'm going to bring sort of the legal lens to wrap up our presentations. Next slide. So one of the sort of zooming back out, what can we possibly do now that we've seen the trends that Atul laid out of private equity investment in healthcare, and then some of the early research emerging about some of the effects on healthcare quality, outcomes, access, staffing, that Zuri and Jane have been, really did a great job summarizing, but also there's just like a whole body of work that's emerging on these topics. And I think the takeaway here is it's concerning, right? Private equity poses some unique threats and some maybe heightened threats to the healthcare environment, both in terms of cost and spending, but also in terms of quality outcomes and the experience that clinicians have practicing medicine when they actually go through a PE acquisition. What is their practice experience like when it comes to their own professional satisfaction? So one of the premises that, when my colleagues and I have looked at this issue is to think of private equity, if we're trying to think of, well, what are the policy levers that we can apply to this issue, is to think of private equity almost as a divining rod to find market failures and payment loopholes. Because private equity investors are particularly adept at identifying and exploiting healthcare market dysfunctions in the form of payment loopholes or market failures. And they use this ability to find, we use them as a way to signal what are the sentinel pockets of money that are sitting out there. If you notice, not every single type of physician practice specialty is equally targeted by private equity. So why are they looking at particular specialties and not others? What is the revenue playbook, drilling down even further into the specifics? For example, that Jane illustrated with the ophthalmology example is that they have identified a market loophole there in terms of the Medicare Part B injectable drug reimbursement policy. So identifying what the specific revenue playbook in any given healthcare specialty will help us point to whatever the policy loophole, payment loophole, or policy market failure exists, it's being exploited for revenue, then I guess the policy response would be, well, let's close that loophole. That's at least one of the first policy responses. So there isn't, I'm just going to say it now, there's not going to be a silver bullet, but what there is sort of a series of identifying loopholes and attempting in a policy response to close those loopholes. All right, next slide. So I'm just going to go through these a little bit quickly, but again, they're just sort of doing that exercise of when we think about these different types of buckets of specialties, then we can identify what the revenue playbook is, and then what the policy response should be. So for example, as Jane mentioned, the early private equity entry into physician practices was based on the hospital-based specialties. These are the types of specialties where the patient doesn't choose their emergency room doctor, their anesthesiologist. And so the policy loophole here, the payment loophole, was to exploit the possibility for out-of-network surprise medical billing. Because the patient doesn't choose these providers and the payers can't steer patients to in-network providers, there really is no volume loss if an emergency department, a group of emergency room physicians decides just to stay out of network and bill higher out-of-network rates and balance bill for almost every patient they see come through the ED, even if the hospital is in network. So that was a revenue strategy identified by private equity investors. And I guess one could wonder, well, why wasn't this fully exploited to the max before? And I think that there are some sort of professional norms that prevent physicians from doing, again, extracting the maximum amount of profit from a possible billing situation, as opposed to, an investor who has a short-term return as their goal. So the threat of surprise billing, of course, also increases the rates when you eventually do contract for in-network providers. And this strategy was the revenue playbook Of course, then the policy response is to, end surprise medical bills, which we saw several states do, dozens of states do, and then finally the No Surprises Act of 2020 at the federal level that closed this payment loophole. And I guess the footnote to that is one of the biggest private equity-backed emergency room staffing companies, Envision Healthcare, a little less than a month ago declared bankruptcy. And so I think that was almost a direct response to the changed revenue environment. If you close their payment loophole, you close their revenue strategy, and they're declaring bankruptcy. Of course, KKR, their private equity owner, is doing just fine. It's not, as Atul pointed out, it's not necessarily, it doesn't go all the way up to the private equity owner in terms of the reputational hit. Next slide. So the playbook for the office-based procedural specialties that Jane was discussing, like the dermatology, ophthalmology, gastroenterology, those seem to be the types of physician practices that have not typically and historically been attractive to hospital and health system purchasers. So these are practices that are seeking capital investment, they're seeking investors, but they're predominantly procedural in the sense that they do a lot of in-office procedures, a lot of outpatient procedures, a lot of fee-for-service reimbursement. They're not always just sort of on a value-based payment. There's also a steady commercial as well as Medicare revenue stream, as well as potentially even cash revenue for optional procedures, think of LASIK or cosmetic dermatology. In addition, a lot of these types of specialties have the possibility of doing what are called wraparound services. So in addition to just the office visit, the practice can also bill for additional services, whether it's a physician-administered drug, whether it's pathology lab services or physical therapy, that there are additional services that they can keep within the practice and bill for if they can capture those referrals. So the strategy here is to increase the volume of patients, increase the volume of procedures and the intensity of the procedures that are done, keep them in-house within the practice, and also, as Jane and others have alluded to, reduce the staffing levels. So the same number of physicians might be seeing a greater volume of patients, many of whom are seen by mid-level practitioners. Next slide. So the playbook for value-based primary care type practices, which is I think the current cutting edge of a lot of PE activity, is again to build on the market share, use this platform and roll-up strategy to find must-have, well-positioned practices that have strong Medicare Advantage participation, for example, or also just have a good presence in the value-based payment ecosystem, and then partner with the payers, whether it's literally financially partner with the payers or eventually sell to a payer-backed physician organization to create a vertically integrated payvider. So that's a payer and physician practice conglomerate. And so what this allows the combined entity to do is to aggressively use coding strategies, particularly risk-based coding, on diagnoses of the patients or the Medicare beneficiaries, which are then used directly to increase the payment, the per patient payment, for example, under the Medicare Advantage system, but also under a variety of value-based purchasing arrangements. So the strategy here is to grow the Medicare population, the Medicare Advantage population, maximize that budget, and then reduce costs with utilization management. All right, so now I'm going to go on to the next slide, to the policy levers. So if these are the playbooks, then what are the policy levers? The first one is just to close the loopholes that we find are being exploited. So for example, the No Surprises Act was a good example of closing. Makes it sound easy. It was not easy, but it was an example of closing the surprise billing loophole. So what are the other ones? So another one would be to change the Medicare Part B payment system for physician-administered drugs to close the 6% sort of arbitrage loophole that the ophthalmology practices are being pressured to use, for example. Another would be to, again, increase Medicare Advantage coding intensity adjustment to increase recoupment of overpayments of the Medicare Advantage system to get at that sort of coding game that a lot of the primary care acquired physicians are now engaged in. So I think that it's not, again, it's not satisfying. It has a feel of whack-a-mole, but if you identify a payment loophole, I think one of the most direct routes is to close that loophole. All right, next slide. And then another would be antitrust enforcement. A lot of the results here in terms of costs and spending are the result of market power, increasing the market power of these physician practices. The problem is a lot of physician practice acquisitions, even some smaller hospital acquisitions and certainly nursing home acquisitions, are so small that they are not in dollar value, that they're not reported to the federal antitrust enforcement authorities. Right now, the Hart-Scott-Rodino Act reporting threshold is $111.4 million per transaction. So you can imagine a lot of these just don't even get reported at all because they fall below that threshold. In addition, the current antitrust authorities at the federal level are very reluctant to challenge vertical, meaning like payer physician or hospital physician or other types of transactions that aren't just a traditional hospital buying its neighbor hospital in the same market. So there's just sort of a lack of FTC and DOJ oversight in these spaces. And in addition, there are some things that the federal government could do. It could change the reporting threshold. It could allow the sort of accumulation of practices to sort of trigger reporting at a certain point, or just start to increase the scrutiny of these other types of non-horizontal transactions. In addition, states can play a role here as well by supplementing the antitrust. They have parallel antitrust enforcement authority, and some states are expanding their oversight over these smaller deals. All right, next slide. Another is to increase fraud and abuse enforcement. So fraud and abuse sort of gets at the overcoding, upcoding, improper staffing levels, and those types of behaviors that can be used for revenue can look like fraud and abuse when it comes to federal payers. So increasing fraud and abuse enforcement by looking very carefully at the way these arrangements are structured. The private equity firms, because they have a controlling stake, are very deep pockets. That are often very knowledgeable about and in fact at the steering wheel of the practice and coding patterns of the clinical acquired entities. So there could be a potential for significant fraud and abuse liability running all the way up to the private equity owner if they were to be probed and investigated by whistleblowers or by the government. Next slide. And then there are some levers that states in particular could pull as well. And these you heard mentioned the corporate practice of medicine, and there are other types of other state laws that could be strengthened to address, in particular, private equity investment in physician practices. So one is to let me start with the corporate practice of medicine. I think in some ways that's the biggest one. So the corporate practice of medicine, as Jane alluded to, is a historic doctrine that exists in just about every state. It's pretty weak. It's under-enforced. It hasn't really played a role in the practice of medicine in a long time in most places. However, most states have a law in the books that does prohibit or at least limit the ability of lay entities in controlling, employing, and owning physician practices. So there are ways that hospitals, for example, have gotten around this, and traditional other corporate investors have contracted around this. So states could try to, again, close that loophole, that contracting loophole, to try to make it a little tougher to simply contract around the corporate practice of medicine doctrine. They could do so statutorily. For example, there are a couple bills in recent memory from states like California that have tried to do that have not passed, but it would be, I think, a significant way for states to exert some oversight and leave the control not only of clinical decisions but also business decisions in the hands of the licensed physicians, not the private equity backed manager. There are other things that could be done in terms of non-competes, gag clauses, non-disparagement agreements, but I'll sort of leave it at that. There are just a bunch of different employment laws and other things that could protect physicians from the control of the private equity owner. Oh, so we are at time. I'm just going to advance one more slide just to show that there are some levers that can be targeted to PE itself. One is to close the carried interest loophole that Atul referenced, and this is a popular provision that seems to make its appearance most recently in the Inflation Reduction Act. Didn't pass. It was removed at the last minute to guarantee its passage. And then the other is to increase the transparency of ownership in healthcare. And there's a current bill that's being debated or discussed from the House Energy and Commerce Committee that would do just this. All right, so I'll leave it at that, and I'll open it up to some questions.
Great, thank you so much, Erin.